You be comfortable. All the best. Hopefully, it moving and I'll be joining you. Sure. In case you finish before I reach you, you can come to room number 102. 102. Fine. Immediately. I'm going. मैं ध्यान से निकलूं. I should not disturb it. Management of chronic kidney diseases, abnormalities of kidney structure or function. Is it okay?
Hello everyone, we'll be having a CME in around 6 minutes on the topic management of CKD. ठीक ठीक
Everything is clear.
हाँ जी.
Comfortable now.
हाँ 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 हाँ.
नित्य हम अभी लाइव हैं. ओके ठीक है. मोनिका मैम एक बार म्यूट कर लो, मैं प्रवीण को कॉल कर रहा हूँ.
अच्छा. I actually do not know where कहाँ पर है इसका म्यूट का बटन है नॉट. वेट.
सर बात कर लीजिए.
एक बार हाँ म्यूट ही रहने दे.
म्यूट
मैं
करना
कह
है
रहा
ना.
हूँ म्यूट करना है. एक बार प्रेजेंटेशन लगा लेते हैं मैम. अनम्यूट करके प्रेजेंटेशन. Good evening, everyone. Welcome to the 20th CME of CGHS Doctor for CGHS Doctors. Today we have with us Dr. Monika, Specialist of Medicine Department in Armel Hospital. Today's topic of discussion is management of CKD. So just to highlight again to all the listeners, this is a technical presentation which is meant for the doctors of CGHS and not for general public. Uh, shall we begin, ma'am?
Yeah, sure.
So now I hand over the mic to Dr. Monica. She'll be speaking on the management of CKD. Thank you, ma'am.
Good evening, everybody. I'll be talking about the management of chronic diseases. As we see lots of patients of chronic kidney diseases. So, what is basically chronic kidney disease? These are abnormalities of kidney structure or function present for more than 3 months with implications for health. Abnormalities of kidney function may present as decreased GFR, while abnormality of kidney structure may present as kidney damage. So, what are the criteria for this kidney damage? See, albuminuria, that is albumin excretion ratio more than 30 milligram per 24 hours, or albumin creatinine ratio in the urine more than 30 milligram per gram per day. Also, there might be other markers of kidney damage. So, any one of the following, along with decreased GFR, present for more than 3 months, will be taken as chronic kidney disease. So, what all are other markers of kidney damage? These are urine sediment abnormalities. There may be electrolyte or other abnormalities due to the tubular disorders. There might be abnormalities detected by histological testing. There might be structural abnormalities detected by imaging. Also, there might be history of kidney transplantation. These markers of damage, along with decreased GFR, that is GFR less than 60 milliliter per minute per 1.73 square meter, will be classified as chronic kidney diseases. So, this chronic kidney disease is classified based on the cause, GFR category, and albuminuria category. This is known as the CGA classification, and this is very important for all the doctors because this will help categorize the patients into mild, moderate, severe, and further into kidney failure. So, we basically need to know this is very important. If we take the EGFR category in the y-axis, in the negative y-axis, and albuminuria category in the x-axis, A1, A2, A3. So A3 is normal to mildly increased albuminuria, that is less than 30 milligram per gram per day. Moderately increased is 30 to 299, that is you can take it up to 300. And A3 is severely increased albumin in urine. It is more than 300 milligram per gram per day. Now moving on to the GFR categories. GFR categories have been categorized into G1 to G5, with G3 having two subcategories. G1 is more than or equal to 90 milliliter per minute, and G2 is 60 to 90, while G3A is 45 to 59, G3B is 30 to 44, and G4 is 15 to 29, while G5, which is kidney failure, that is end stage renal disease, that is less than 15. So here we can see that G1, G2 with mild albuminuria has very low risk of progressing into renal failure, while G1, G2, and G3A with mild proteinuria, that is mild albuminuria, and G1 and G2 with moderate albuminuria will be classified into the yellow category, that is the moderately increased risk of developing into chronic renal failure. While the category G1A3, that is severe albuminuria, and G2, that is less 60 to 90 and above 90 GFR, that will be categorized into the orange, that is the high risk, along with G3A, A2, and G3B, A1. So we have to be very diligent in writing the GFR category of the patient as well as albuminuria category of the patient. That is G1A1 will be in the low risk category, while G1A3 will be in the moderately increased risk category of developing into kidney failure. Similarly, G4A1, G4, G4 and G5, these will be the red risk, that is very high risk of the category of CKD. So, first of all, what is GFR? GFR is the volume of blood that is being filtered from the glomerular capillaries into the Bowman's capsule. So this GFR per unit time, and we cannot have exact representation of GFR. So we use estimated GFR by using the formulas of Cockcroft-Gault formula or the MDRD equation and the CKD epidemiology collaboration CKD EPI equation. The most accurate of all these estimated GFR calculators is the CKD EPI calculator. It takes into account the serum creatinine and age of the patient, and obviously the male female has different uh, classification according to the GFR. The Cockcroft-Gault formula uses age, weight, and serum creatinine, and this might be sometimes falsely positive when the patient is in ESRD, he has fluid overload. So it may wrongly show a higher GFR. And obviously for all females, because they have more body surface area, so there is a certain number, certain constant which has to be multiplied whenever we calculate the EGFR. Similarly, in MDRD, it does not require patient's weight, but it underestimates the measured GFR values at more than 60 milliliter per minute per 1.73 square meter. There are further many calculators, but the most accurate and most used is CKD EPI, and there are various CKD calculators available online. The most well known is the National Kidney Foundation calculator. So, why do we need to take GFR into account, and why is it important? See, very small changes make a very big difference. In this slide, as you can see, a patient having a eGFR of 100 at the age of 25 years, if there is a GFR loss of more than 1 milliliter per minute per year, beginning at the age of 5 years, that can result in into chronic kidney disease within a normal lifespan. Similarly, if it is more than 2 milliliters per minute per year, then he might have the CKD at the age of 70 years. But if the patient has decrease in GFR of more than 5 milliliter per minute per year, then he might develop CKD a lifespan of 20, within a span of 20 years. So that is very important to take care of the EGFR calculation. If we are able to prevent, if we are able to diagnose early CKDs, and we are able to halt or minimize or delay the progression of CKD, that will be a very important thing for the patient. So how do the chronic kidney disease progress? First, there are normal patients. The kidney is normal. So if the patient is normal, the kidneys are normal, and the risk factors are present, we have to screen for the risk factors. Suppose the patient is diabetic, patient is hypertensive, patient is an old age male, then we have to take care of the risk factors, and we have to be vigilant that what all risk factors are important, and we can reduce the risk. For example, as we learn later, that in diabetic patients, adequate control or aggressive control of the glycemia is very important. The glycemic index has to be maintained. And similarly, a hypertensive patient, his BP has to be under 140/90 or below 130 by 80 millimeter of mercury, so that we can we can reduce the risk, and we can identify the patient in which category will he come to, and we can further monitor the patient. So when there is increased risk, so we have to screen for kidney injury. Suppose a diabetic or hypertensive patient, he develops acute kidney injury, he goes into hypovolemia, he has diarrhea episode, he goes into hypovolemia, he develops acute kidney injury, then we have to immediately start the treatment so that his acute kidney injury does not develop into chronic kidney injury. Similarly, once the patient has the injury has been done, we need to need the diagnosis and the treatment, plus we need to prevent the progression of the disease. For example, most common in India, and I'll be repeating all throughout my presentation, that diabetes and hypertension is the two most important things we need to look out in all the patients. And then after injury, slowly and steadily, the patient's GFR will decrease. At this point, we have to prevent the progression. There might be complications due to decreased GFR. He might from G1, A1, he might progress to G2, A2. So we need to know when to take the right steps to prevent the progression of the complications. And plus, we need to treat the complications. We have to advise for the further timely renal replacement therapy in such patients. Once the kidney failure has developed, then dialysis and transplantation is inevitable, and we have to basically first halt the progression or maybe delay the progression of CKD diseases so that the quality of life of the patient improves. So primary prevention is done when there is no disease in the patient. Secondary prevention is done when there is the in patients which have developed established CKD. And tertiary prevention is to soften the impact of the chronic kidney diseases. So what all will be done in primary prevention is that appropriate management of CKD risk factors would be done. In secondary prevention, once there is established CKD, we need to diagnose, or we need to classify, we need to stage the CKD, and so that we have time for a timely referral to the nephrologist, and we can take various measures for the prevention of CKD progression. And in tertiary prevention, when the patient has developed florid symptoms, he's in stage 4 or stage 5, when there are symptoms are very confluent, then what we need to do is regulate the CKD progression and also take steps to prevent the worsening of renal function and improve the management of CKD to prevent mortality and morbidity. So, what are the risk factors for CKD? I have classified the risk factors for CKD into non-modifiable and modifiable. Non-modifiable, non-modifiable risk factors would be age. Elderly, obviously, they are more prone to progression of CKD, along with other factors. Sex, male patients are much more prone for CKD. Then ethnicity, certain genetic diseases like Fabry's and Alport's, polycystic kidney disease. Low birth weight, it has reduced renal mass that may lead in later on in life, or even a small event can lead to a progression of CKD. Also, any other family history of kidney diseases. And in modifiable causes, where we can work upon is if the patient has diabetes, impaired glycemic control, hypertension, dyslipidemia, lifestyle factors, we can work on the lifestyle factors. Smoking is to be prevented, sedentary lifestyle that can lead to CKD, obesity in itself, metabolic syndrome, high protein diet, these can all lead to CKD. Also, presence of prior cardiovascular disease or prior acute kidney injury that can lead to CKD. Anemia per se, it is a complication of CKD. It can also, it's also a risk factor for CKD. And also environmental exposures like cadmium, lead or mercury and drug toxicities can lead to CKD. So now to the causes of CKD. Very important world over and in India is diabetic kidney is the most common. So being doctors in maybe wellness centers or maybe hospitals, we need to be very particular about the glycemic control of the patients, of diabetic patients, and hypertension, that is BP control of the patients. Other causes of CKD in vascular diseases are ischemic renal diseases, In glomerular diseases, we have primary and secondary causes. In primary causes, most common being lupus nephritis, vasculitis, focal segmental glomerulosclerosis, IgA nephropathy, membranous nephropathy. And in secondary glomerular diseases, we have infections due to hepatitis B, C, HIV, and malignancies like leukemia, Hodgkin's lymphoma, carcinoma, and also amyloidosis. In cystic diseases, we have polycystic kidney disease, while in tubulointerstitial diseases, UTIs, nephrolithiasis, obstruction, sarcoidosis, multiple myeloma, and drugs. These all can cause chronic kidney disease. So, what are the goals of CKD management? The treatment objectives are to prevent the progression of CKD to end stage renal disease or renal failure, to prevent the complications of CKD, to prevent cardiovascular events and death, that is, heart attacks, heart failure, sudden cardiac death, and stroke, and to prepare the patient for timely dialysis or transplantation. So, how do we primary prevention? How do we prevent CKD progression? These all these factors can be used for primary prevention as well as secondary prevention. First of all is the lifestyle factors. There should be We should advise all patients to stop smoking, alcohol restriction. The dietary guidelines for CDC recommends that less than equal to 2 drinks per day in men and less than equal to 1 drink per day in women. We have to restrict the alcohol intake of the patients, of CKD patients. Exercise, 30 minutes of moderate intensity exercise for 5 days per week is important for all the patients. Weight reduction, target BMI should be 18.5 to 24.9. That is, we have to maintain the BMI less than 25 kg per square meter. Also important is water and electrolyte balance. We should advise the patient to take daily fluids, which is equal to the previous day's urine output plus 600 ml for the insensible losses. Avoid any kind of nephrotoxic drugs, that is NSAIDs, IV contrast media, aminoglycosides, nitrofurantoin, and herbal medicines. Herbal medicines is very much in vogue in India nowadays. So we should try to convince the patient to avoid such herbal medicines because they have very different pharmacodynamics and different pharmacokinetics in every individual. Moving on to the diet, the patient should be restricted. Patient should have restricted protein intake, maybe from zero point 0.8 to 1.3 gram per kg per day. Zero point 0.8 gram in a 60 kg individual will come to around 48 grams of protein per day. And a single, like if a patient takes an egg, and egg contains 6 gram of protein per day, so accordingly we have to, and Indians generally they have very less protein intake in their diet, so we must restrict the intake of protein for such patients because they'll otherwise cause albuminuria, and that can further cause proteinuria, and the CKD risk can increase. We must promote plant-based diet, avoid potassium and phosphorus-rich foods, like we have to avoid banana, coconut, other dry fruits, berries. Berries are good in, I mean, they have low potassium, but other processed food like poultry foods and meat products, milk and yogurt, potatoes, tomatoes, all these contain, we should at least know certain uh, food materials which are known to have high potassium or high phosphorus content. And all the aerated drinks, all the dark colored aerated drinks, cocoa, chocolate, all these should be avoided because they have high potassium and high phosphorus. Also, patients should avoid highly processed food and refined food. And sodium intake should be less than 2 gram of the sodium per day or less than 5 gram of sodium chloride per day. Now, the role of blood pressure management. The hypertension is very important, and control of BP is of utmost importance in advanced CKD. We have to, as I talked earlier, the all we have to take care of all the non pharmacological measures like reduction of sodium chloride, promotion of exercise, weight reduction, smoking cessation, and decreased protein intake. And this hypertension, I'll be just mentioning basic points, because hypertension itself is a bigger topic. It's a topic for a lecture in itself. So I'll just touch upon few points which are important along with CKD. So initially we'll start with a renin angiotensin aldosterone system inhibitor, that is ARBs or ACE inhibitors initially. And we might add a calcium channel blocker or a diuretic. A thiazide diuretic can be used in stage 1 to 3, and later on loop diuretics can be added for stages 4 and 5. Also, in the later stages, we can add beta blockers or alpha blockers or moxinidine, as the case may be. So, associations of ACE inhibitors and ARBs are not recommended because it causes a lot of hyperkalemia. And aldosterone antagonists should be used in exceptional conditions. So, here we see that angiotensin aldosterone system inhibitor reduces the progression of diabetic nephropathy. There is the evidence of supporting of use of ACE inhibitors or ARBs in patients with diabetes. So when we see a patient with G1A2, I mean, the patient has GFR more than 15 and has moderately increased or severely increased albuminuria, then we'll start the ACE inhibitors or ARBs, because they are found to be renoprotective. They minimize the CKD progression. So it will start from, we can start from stage 1 to stage 4 of the CKD with patients having albuminuria, that is protein more than 30 milligram per gram per day. Also, in patients without diabetes, we can use in stage 1 to stage 4 with patients who are having severely increased, that is more than 300 milligram per day of proteinuria. So here also it has been known that the ACE inhibitors and ARBs, they slow down the CKD progression. So what basically they do is they decrease the risk of end-stage renal failure by around 30%. That is, relative risk is reduction is by zero point 0.3, and it improves cardiovascular mortality rates as well. It has better BP control, and there is fewer need of other antihypertensive medication. There is less need to add drugs with no mortality benefit like hydralazine and alpha blockade. So we can continue. Recent studies and recent guidelines have indicated that we can use ACE inhibitors or ARBs in people with CKD even when GFR falls below 30 ml, because we can use it, but we have to be careful about the risk of hyperkalemia. Also, we need to avoid any combination of ACE inhibitors and ARBs. Now, important next in the management is the blood sugar management. The goal is to maintain HbA1c level of 7%. And so this good glycemic control reduces the progression of CKD, and also decreases the incidence of proteinuria, and also maybe decrease the end stage renal disease. So first, in every management, first we should always go in for therapeutic lifestyle changes, that is healthy diet, physical activity, smoking cessation, and weight management. The first line therapy in these would be SGLT2 inhibitors along with metformin. Metformin can be used when the GFR is more than 30, that is till stage 3 we can use metformin. And SGLT2 inhibitors can be added, can be used alone also, or they can be added with metformin. These are continued SGLT2 inhibitors. They can be continued till dialysis or transplantation of the patient. Also, these then we need to regularly assess the glycemia control, the albuminuria, the BP level, the cardiovascular risk, And the lipid management should be done. This assessment should be done regularly at the interval of 3 to 6 months for all diabetic type 2 diabetes patients. Then additionally, GLP-1 analogs may be added. GLP-1 analogs are added if the patient requires individualized glycemic target control is required. Also, other glucose lowering drugs are needed to achieve individualized glycemic target. Example, we can use insulin in such patients. Next is the we use renin angiotensin aldosterone system inhibitors in maximum doses. This is the first line therapy in all patients of type 1 and type 2 diabetes. Non-steroidal mineralocorticoid receptor antagonists may be used if the albumin creatinine ratio is more than 30 and the potassium is normal. And rest of the things like calcium channel blocker and diuretic has to be added to achieve individual BP targets, which should be less than 130 by 80 millimeter of mercury. And steroidal mineralocorticoid receptor antagonists will be used for resistant hypertension if and only if the EGFR is more than 45. And we'll use moderate or high intensity statin in all patients. Also, antiplatelet therapy is important for clinically established atherosclerotic cardiovascular disease, and ezetimibe may be added based on atherosclerotic vascular disease risk and the lipid profile of the patient. So, this assessment is important and they have to be done every 3 to 6 months. So, sodium glucose co-transporter inhibitors, SGLT2 inhibitors. What all medicines are there in this? There are empagliflozin, canagliflozin, and dapagliflozin. What the SGLT2 inhibitor does is they improve the glycemic control. Weight loss is a benefit or maybe sometimes a side effect in such patients. Weight loss of up to 15 kgs, maximal is up to 5 kgs of weight loss has been seen with starting SGLT2, but few patients have reported significant or drastic weight loss of around 15 kgs also. And it also causes osmotic diuresis. So, therefore, we have better BP control in these patients. If there is osmotic diuresis, so that then along with this, you have to decrease the loop diuretics accordingly. So why is this SGLT2 inhibitor important? It is important because it reduces albuminuria, it provides renal protection as well as it provides cardiovascular protection. So nowadays, more of SGLT2 inhibitors are being used in diabetic patients who are initial stages of CKD and along with hypertension. So this has proven to reduce the renal injury as well as it has cardiovascular protection. So these SGLT2 inhibitors are started in category 2 to 3 of the CGA staging, and it can be used in mild to moderate and as well as severe albuminuria of the patient. And also it has been SGLT2 inhibitors can used in patients without diabetes, patients who are having severe proteinuria, that is severe albuminuria of more than 300 milligram per day. They can be given SGLT2 up to 25 ml of GFR, they can be given. So in stage 2, 3 and 4, they can be given safely in cases of severe albuminuria. Next is the glucagon-like peptide receptor agonist, that is GLP-1 analogs. What they do is they decrease hyperglycemia, they decrease insulin resistance, they decrease weight, they decrease blood pressure, and they decrease NADPH oxidase and decrease ROS production, reactive oxygen species production. They basically, these GLP-1 analogs, they are basically incretin mimetics. So they basically decrease insulin dependent glucose dependent insulin release. They increase glucose dependent insulin release. They decrease the appetite. They decrease the they suppress the appetite, and they are important in diabetic kidney diseases and cardiovascular diseases. So there is decrease of hyperglycemia, there is reduction in insulin resistance, there is decreased body weight, there is decreased blood pressure. All uh, this effects of GLP-1 agonists, they suppress inflammation, and they specifically suppress the oxidative stress in the body. Next is the mineralocorticoid receptor antagonists. They are divided into two categories, steroidal and non-steroidal. Steroidal are those conventional and traditional MRAs, that is spironolactone and eplerenone. And non-steroidal MRAs are the newer ones. These are the finerenone, which is being used currently, and which is gaining traction in current usage in CKD, in management of CKD patients. Benefits are that it lowers the progression, that is bursting of CKD, and it decreases risk of kidney failure, it decreases risk of CV death, non-fatal MI, stroke or heart failure exacerbation, and it decreases albuminuria. Also, its main side effects are hyperkalemia. So we always start finerenone when the potassium level is less than 5.5. That is between 4.8 to 5.5. You can start the non-steroidal MRAs. So hyperkalemia is well known with side effect. Hypotension is well known. Hyponatremia is well known. Hyperkalemia is hyperkalemia is less than the other conventional or traditional steroidal mineralocorticoid receptor antagonists used. And also the gynecomastia, which is common with steroidal MRAs, it is not found with finerenone because it has selective affinity for mineralocorticoid receptors. So now moving on to the modification of other CVD risk factors in CKD. First of all is the lipid lowering. We need to look for cardiovascular risk factors. So we need to do a lipid profile of the patients every 6 months or maybe once a year. So lipid lowering therapies following 3 months of therapeutic lifestyle changes, pharmacotherapy for LDL more than 100 should be started. Initial treatment should be with statins, and fibrates are to be added when the triglyceride is more than 500 milligram per deciliter in CKD 5 patients. But now the newer guidelines say that any increase in cardiovascular risk, not just the elevated LDL, is a primary indication to initiate treatment. Also, antiplatelet therapy may be required, that is, low dose aspirin may be required for secondary prevention in people with CKD and established ischemic cardiovascular disease. Also, anticoagulation may be required in certain patients, indications being atrial fibrillation, venous thromboembolism, or prevention of dialysis access thrombosis. Newer oral anticoagulants, that is dabigatran, rivaroxaban, apixaban, edoxaban, they have been found to be superior to vitamin K antagonists, that is warfarin. So now moving on to the a guide to the frequency of monitoring according to GFR and albuminuria category. See, if the patient is in category 1 and category 2 with mild albuminuria, then mild to moderate albuminuria. Also, if it's a patient is in category 3A and with mild albuminuria, then only once a year monitoring is required of GFR, of albumin. But if the patient is in category 1, 2, and category 3A, 3B, having having mild to moderate proteinuria, and the G1, G2 having severe albuminuria, then we require at least twice yearly monitoring. That is, within a gap of 6 months, we'll be requiring twice a year monitoring for such patients. Also, in category 3A with severe albuminuria, category 3B starting from moderately increased albuminuria and severely increased albuminuria, as well as in category 4 having mild to moderate increase in albuminuria, we'll be monitoring the patient thrice a year. And in CKD, 4 patients who are having severe albuminuria, and in ESRD patients, that is patient having kidney failure less than 15 milliliter GFR, they will require more than 4 times uh, monitoring of GFR and albuminuria category, so that we can accordingly intervene in the management of the patients. We can send the patient to the nephrologist. These all things have to be taken care of. So management of CKD complications, these are complications is when the patient will develop patient has established CKD, and now patient is become symptomatic. He's not in the category 1, 2, 3. He's probably, once the complications develop, patient usually remains asymptomatic in category 1, 2, 3, but patient has confluent symptoms starting from category 4 and 5. So once the patient has landed up in complications, he need emergency admission. He will be treated in the hospital. So what are the? I'll quickly rush through the what are the management of such complications when the patient has significant symptomatology of CKD. So there will be fluid and electrolyte imbalance firstly. So we'll treat his fluid overload. Fluid restriction has to be done. His input has to be maintained. Input should be equal to the previous day's output plus 600 ml. Diuretics can be used. Furosemide can be used. Torsemide can be used. Furosemide, torsemide, they can be used up to 400. Furosemide can be used up to 400 milligram per day, and even torsemide can be used 200 up to 200 milligram per day. And eventually, if the fluid overload is not responding to oral or IV treatment, then eventually we'll have to do the dialysis of the patient. Treatment of hypertension, as I mentioned earlier, that the goal is to maintain the BP to less than 130 by 80 millimeter of mercury. So we'll use renin angiotensin aldosterone system inhibitors, that is ACE inhibitors or ARB inhibitors, ARB blockers, and along with calcium channel blockers, along with diuretics. Initially, we might use thiazide, then loop diuretics, then non-steroidal mineralocorticoid receptor antagonists, beta blockers, and alpha blockers. So these are according to the other guidelines, JNC 8 guidelines for the management of hypertension. Treatment of anemia. Treatment of anemia is initiated when the hemoglobin drops to below 10 gram per deciliter. We can start with tablet ferrous sulfate 200 milligram 3 times a day, or injectable ferric carboxy maltose, which is being used in hospitals nowadays, can be used. Before starting any erythropoiesis stimulating agent, that is erythropoietin, darbepoetin, or apoetin alpha injections, we need to correct the iron deficiency of the patient. Anemia in CKD is a topic for lecture in itself, but I'll be just mentioning a few important practical points, that before starting any erythropoiesis stimulating agents, we should take care of the uh, iron profile of the patient. The patient should have at least transferrin saturation of 30 to 35%, 30 to 50%, and transferrin saturation level should be below 300. And so it is important that before starting this erythropoietin, the iron stores of the patient are at least the deficiency, iron deficiency is not there. Then treatment of hyperkalemia, we may use 10% calcium gluconate IV, 10 to 20 ml over 10 minutes, and regular insulin 10 units in 50 ml of 50% glucose. Then treatment of metabolic acidosis is important, because correction of metabolic acidosis may slow down the CKD progression and improve patient's functional status by attenuating the catabolic state. We should try to maintain the bicarbonate levels in the blood to up to 20-22 milliequivalents. When there is severe metabolic acidosis, that is bicarbonate levels less than 10 milliequivalents per liter, then we need to give injectable sodium bicarbonate. Otherwise, oral sodium bicarbonate tablets can be used to maintain the level up to 20 to 22 milliequivalents per liter. Now, the treatment of hyperphosphatemia is also important. We have to reduce the dietary intake of phosphorus. So we have to advise the patient accordingly that certain fruits, foods have their consumption should be reduced. Calcium-based phosphate binders like calcium acetate carbonate, 6x7 milligrams can be used along with food, or non-calcium based phosphate binders like sevelamer and lanthanum can be used. Then, in treatment of hypocalcemia, calcium citrate up to 1 gram per day can be given. Vitamin D supplement with oral or injectable cholecalciferol. When vitamin D is less than 30 nanogram per ml, we give 60,000 international units weekly for 12 weeks, then followed monthly for up to 6 months. And calcitriol is active form of vitamin D. This has to be given also to be given for up to 6 months. It promotes vascular calcification. So the active form of vitamin D, that is calcitriol, is not that much preferred. In place of that, we can give cholecalciferol, which does not have any such complications. And treatment of hyperparathyroidism, again, we'll give calcitriol, vitamin D analogs, and calcium mimetics. Treatment of pruritus, antihistaminics can be used, cholecyramine can be used, capsaicin cream can be used. And in treatment of bleeding, desmopressin can be given zero point 0.3 microgram per kg IV for 15 to 30 minutes. Now, vitamin replacement. Vitamins, water soluble vitamins, as we know, is removed by dialysis and contribute to malnutrition and vitamin deficiency syndromes in all patients of dialysis. These vitamins include the ascorbic acid, thiamine, riboflavin, biotin, folic acid, and pyridoxine. So, all patients of dialysis, undergoing dialysis, they should receive vitamin B complex and vitamin C in their nutritional supplement. Now, moving on to renal replacement therapy. That is, this is at the end of the spectrum of the CGS staging, where the patient is in 3B, stage 4 or stage 5. Patient, we'll see what are the indications for dialysis. Patient can be given two options of renal replacement therapy, that is dialysis and renal transplantation. Dialysis I briefly touched upon, because this, again, every slide here is again a topic for a lecture. So I have briefly touched upon that in dialysis we can do hemodialysis, we can do peritoneal dialysis, and liver transplantation may be live donor related or unrelated and cadaveric. So in dialysis, hemodialysis and peritoneal dialysis are both equal in terms of efficacy, but hemodialysis has found to be superior to peritoneal dialysis in some studies due to the complication like peritonitis, which then subsequently leads to septic shock, which is associated with peritoneal dialysis. So, therefore, hemodialysis has been preferred to peritoneal dialysis. Now, what are the indications for dialysis? There are certain absolute indications and there are certain relative indications. Absolute indications is patient is suffering from refractory hyperkalemia. Even after medical management, the potassium is more than 6 milliequivalents per liter. There is refractory acidemia, the, metabolic or mixed acidosis with pH of less than 7.5 in spite of treatment with bicarbonates. There are signs and symptoms of uremia, bleeding, pericarditis, encephalopathy, as we regularly see in patients. And plus, there is refractory volume overload with organ edema. Also, they may also be used, the hemodialysis or peritoneal dialysis. It can also be used for in cases of toxicity or overdose of easily digestible medications or drugs. And relative indications for dialysis are oliguria or anuria, that is urine output is less than 200 ml per 24 hours, or azotemia, that is blood urea nitrogen is more than 100 milligram per deciliter. Hypermagnesemia in an anuric patient with loss of 10 reflexes when magnesium is more than 8 milliequivalents per liter, and anticipating worsening electrolyte problems with AKI, as in case of tumor-lysis syndrome, rhabdomyolysis. So, renal transplantation, what is done in renal transplantation is that the live donor or related or unrelated or cadaveric kidney is transplanted into the lower pelvis of the recipient, and then the patient is started along with immunosuppressants. This renal transplantation basically improves the um, quality of life of the patient as compared to a patient who is on dialysis. So, touching upon the immunizations, CDC recommends following immunization in patients with CKD on dialysis. These are the guidelines recommended by CDC. Influenza vaccine is to be given annually for all CKD patients, and pneumococcal vaccines for patients with ESRD has to be given at 0 to 2 months, and booster dose at 5 years. While hepatitis B vaccine, it is different from the vaccination schedule in normal patients. In normal patients, it is 016 at 016 months, while in CKD patients, this hepatitis B vaccine is given at 012 and 6 months, or 2 ml of the hepatitis B vaccine is injected. So now, when to refer to a nephrologist? We see here that the KDIGO classification here has given a traffic light kind of categorization of the CKD patients. The green one, that is patient in category stage 1, stage 2, that is up to 60 GFR with mild albumin. You can treat the patient under yourself and at your center. But patients having in stages stage 4, stage 5, even stage 3, who are having severe albuminuria, while in stage 3B having moderate to severe albuminuria, then you have to refer such patients to the nephrologist. In other patients, the ones in yellow, patient in stage 1 and stage 2 with moderate albuminuria, you can monitor the patient, as well as patient in stage 3A with mild albuminuria, you can monitor the patients. But this orange zone, that is stage 3B with mild proteinuria, stage 3A with moderate proteinuria, albuminuria, and stage 1 and 2 with severe albuminuria, you have to monitor or maybe refer such patients to a nephrologist. This is important. This KDIGO classification, CGA classification of CKD is important because we need this to classify the patients. We need to monitor when to monitor the patient, when to refer the patient. So, any acute kidney injury or abrupt sustained fall in GFR, or GFR is less than 30, that is GFR category of CKD categories of 4 and 5. But the general consensus is that below anyone below 45, we refer to the nephrologist. That is starting from G3A onwards, stage 3 onwards, we refer to the patients. But if in stage 3 also, stage 3, we can monitor the patient, only the patients having severe albuminuria in stage 3, they need to be referred to the nephrologist. Stage 4 and stage 5 obviously need to be referred to the nephrologist for further treatment. Also, consistent finding of albuminuria, as I discussed now. Progression of CKD is there. Patient in G1A1 is progressing to, you have to monitor him yearly. Next year he comes to you, he is in G2 and A3. Then the patient has to be referred to a nephrologist. So this progression you have to take care of. Frequency should be according to the guidelines. We should monitor the patients so that they get a timely referral to a nephrologist. And any urinary red cell cast, that is RBC more than 20 per hyper field, sustained and not readily explained, they can also be referred to nephrologist. CKD and hypertension refractory to treatment with 4 or more hypertensive agents, antihypertensive agents, they also have to be referred to nephrologist. Patient having persistent abnormalities of serum potassium, not being managed by conventional medicines or treatment or IV injectables, they have to be referred to a nephrologist. Recurrent or extensive nephrolithiasis, any hereditary kidney diseases, they have to be referred to, or any other kidney diseases. So finally, I would like to sum up all the management in this slide, where first we start with diagnosing CKD and determining its likely cause. We have to determine what are the risk factors. Risk factors are obviously there. Identifying the risk factors and then acting upon them comes in the primary prevention. In secondary prevention, we have a patient with acute kidney injury. Initially, it was acute kidney injury because the duration was maybe of a few weeks, few days, few weeks, or few months. But once the patient has developed acute kidney injury, you are monitoring the patient, and that acute kidney injury now has taken a long time in recovery. It is now more than 3 months. Then we have to determine its cause. What are the cause? Whether it is diabetes, whether it is hypertension, whether it is any other hereditary disease, whether it is polycystic kidney disease, or there is NSAID abuse. Okay, NSAID abuse will mostly cause interstitial nephritis. And so now, after diagnosing CKD, we have to risk stratify. I mean, we need to categorize the patient according to the GFR levels and the albumin levels. They Now the GFR, it tells about the functional status of the kidneys, while the albumin tells us about the structural defects or structural, more the structural abnormality, more is the albuminuria. So we need to categorize these patients in two axes, that is the GFR according to decreasing GFR, and according to increasing albuminuria, the patients will be categorized. The patient who is at the end of the spectrum, whether it is in GFR, whether the patient is below 15, below 30, below 45 GFR, and the patient is having mild, moderate albuminuria or severe albuminuria, they are at the end of the spectrum. They require specialized services. But what we need to do is we need to act early. We, as primary point uh, caregivers, the patient first comes to us, then we need to obviously start on medications which have shown to provide renal protection as well as cardio protection to such patients. So we need to work when the patient is in G1, from maybe A1 to A2, that is mild to moderate proteinuria, or the patient is in G2, A1, A2, patient is in G3, G3A, A1, A2, A3. A3 again is severe proteinuria, so patient will be referred to a nephrologist. But we need to act in initial stages of the CKD, where we can, with our intervention of giving SGLT2 inhibitors or GLP-1 analogs or renin-angiotensin aldosterone system inhibitors or maybe non-steroidal MRAs, we can delay the progression of a patient from G1A1 to maybe G1A2, so that in a year, that loss of kidney function, loss of kidney structure, that we can prevent, that can be delayed. So if the patient has no diabetes, and if the patient has diabetes, we can accordingly start um, SGLT2 inhibitors and ARBs and ACE inhibitors. And in all patients, we need to address the lifestyle. We need to convince patients, and we need to advise patients of the lifestyle measures that need to be undertaken to prevent the progression of CKD. Target BP should be less than 130 by 80, and statin should be given to patients if their 10-year risk is more than 10%, GFR is less than 60 and age is more than 40, if GFR is less than 60 and age more than 18 with diabetes, and in patients with CKD 1 and 2 with albuminuria. And in all such patients, we need to monitor with the blood pressure, the glycemic control of the patient, the albuminuria category of the patient. So these need to be taken care of, and also tight glycemic control should be undertaken early itself in the CKD category, so that the progression is delayed. And obviously refer if the GFR is below 45, if the urine protein is more than 300 milligrams per liter, and diabetic kidney disease with renal disease not in proportion to diabetes, or there is suspected renal artery stenosis, suspected genetic or hereditary cause for kidney disease. So thank you all for patient listening.
Thank you, ma'am, for a wonderful presentation. It was a pretty elaborate presentation and it covered nearly everything. So, we have a question from Dr. Sushma. She is asking, what about the admissibility of vaccines? In CGHS, there is a rule for admissibility of vaccine which says that uh, only hepatitis B and influenza vaccine is allowed. Then, what about the recommendation? It changes things.
Okay. See, guidelines say that influenza vaccine and hepatitis B vaccine they have to be given along with pneumococcal vaccine. So, what we can do is influenza and hepatitis B vaccine probably they are getting in the dispensaries, but the recommendations say that pneumococcal vaccine has to be given for patients with ESRD, that is in stage 5 of the CKD.
Sure. Uh, I think we have already covered this question, but we'll repeat it anyhow. How can a doctor sitting in wellness center help out in management of CKD? Because it's not just a nephrologist who's treating the patient.
Yes, we see we need to like blood pressure monitoring that can be done in a wellness center. The patient's glycemic control, blood sugar fasting, that should be less than in a diabetic patient, that should be less than 130. Okay, and the postprandial that should be less than 180 milligram percent. And these tight glycemic control that can be done in the plus the BP monitoring that can be done at the wellness center itself. No need to, at least if now there are GFR calculators available online, everybody has a phone, they can easily just age and sex of the patient and serum creatinine levels, they have to be entered, and we can easily, you know, at least we can categorize the patient. Then we have a clear understanding or maybe a rough understanding of where the patient lies. If the and plus a very important test is albuminuria test. Nowadays many patients come with urine albumin creatinine ratio. So this albumin test can be done for this patient, for the patients, for diabetic and hypertensive patients. If it is more than 300 milligram per day, then obviously the patient has to be referred. But below, like the mild and moderate proteinuria patients, they can be managed then and there itself. And accordingly, the frequency of monitoring has also been given in the guidelines, that in low risk patients, that is category 1 and category 2, with the mild albuminuria, they can be monitored only once a year, while the patients having increased, that is moderate to severe proteinuria in category 1, 2, 3, and 3A and 3B, they need to be monitored more frequently, maybe uh, twice a year and thrice a year. And other patients are naturally, if the GFR is less than 45, then the patient can be, obviously they can be referred to a nephrologist. So this is how they can help in wellness centers, at least BP monitoring. If the patient is on antihypertensive medications, suppose a patient has been started on ACE inhibitor, a calcium channel blocker, and a diuretic, still the patient, and plus a beta blocker, still the patient is having high blood pressure, it is resistant to any of your treatment, then the patient needs to be referred to a nephrologist or maybe a higher center. Not, it is not necessary to refer every diabetic and every hypertensive to a nephrologist. Some patients we can monitor in the at the level of the wellness center itself.
All right, ma'am. We have another question from Dr. Nirmal. What is the role of finrenone in the CKD?
Okay, finerenone is a newer non-steroidal mineralocorticoid receptor antagonist. So, Finerenone has started gaining popularity nowadays because it has it has hyperkalemia, but lesser hyperkalemia as compared to other conventional or traditional MRAs, steroidal MRAs, that is eplerenone and aldactone or spironolactone. So, what basically we need in Finerenone, we need to monitor the potassium level. If it is between 4.8 to 5.5, then we can initiate this, and the EGFR is more than 60, then we can initiate with 20 milligram per day of finerenone. But if the EGFR it decrease, initially we have to start with 10 milligram. We have to start with 10 milligram, and we have to monitor in this after 2 months. If there is EGFR reduction less than is more than 30%, and the potassium level is normal, then we can escalate it to 4 milligrams per day. So basically, the side effects which we experienced with other traditional ones, that is spironolactone or aldactone, that can be the it is less. That hyperkalemia is comparatively lesser than that. Also, as finerenone is mineralocorticoid receptor selectivity is there, it is in more potency is there with mineralocorticoid receptors. So cases of gynecomastia and other sexual symptoms seen with use of spironolactone or aldactone, that is not there with finerenone. So this can be safely used till up till 25 GFR. Below 25 GFR, it has to be stopped.
All right, ma'am. I think that's the end of the questions. Uh, I think the presentation was elaborate enough, and we can close this session for today. Thank you so much for giving the presentation, ma'am.
Thank you. Thank you so much.